Morning, everyone. Thank you for coming to the first Winship Grand Rounds of November. It is my honor and pleasure to introduce you to Dr. Nadine Tung. She's an associate professor in Harvard Medical School. She's the chief breast medical oncologist at Beth Israel Deaconess Medical Center. She's also the director of the Cancer Risk and Prevention Program. So without further ado, welcome, Nadine.
Thank you. Okay. So I'm going to try to cover a lot of territory today. We'll see if we get to the end. But I'm going to first talk about hereditary breast cancer and just talk about which genes, how frequent are the mutations in those genes. Then talk about managing the breast cancer patient who has hereditary breast cancer. First, an update on BRCA1 and 2, local treatment, systemic treatment. And then talk about some of these newer, more moderate risk genes, ATM, CHEK2, PALB2. And if we have time, I'd love to just talk for about 5 minutes about some of the work we've done for those who do not have cancer yet, but who've inherited these moderate risk genes. What kind of surveillance, what kind of risks do they have? Not sure we'll get to that, but we'll try. Okay, so about 10% of breast cancer and about 15 to 20% of ovarian cancer is due to autosomal dominant inheritance of a single gene mutation, either from one's mother or one's father. And I would estimate about 40% of this breast cancer risk, and probably about 2/3 of the ovarian cancer risk, is attributed to BRCA1 and 2 mutations. The rest, something else. So for those not familiar with thinking about cancer susceptibility genes, this is how we think about it, and this is for breast. So on the x-axis, you have how frequent these mutations are in the population. And on the y-axis, what you have is how high is that risk of cancer if you inherit a mutation in that gene. So high-risk genes, or mutations, confer a greater than 5-fold risk of getting cancer, no matter what cancer you're talking about. So up here we have our familiar genes and our syndromes, BRCA1 and 2. Very rare, the mutations, but very high, the cancer risk. Over 10-fold, really, for these mutations. And then next, we have these newer genes, ATM, CHEK2, PALB2, these newer genes that are being identified. And we call them moderate risk genes because if you have a mutation, they confer a 2 to 5-fold risk of cancer. This is for breast cancer. But you can see these mutations are a little more common. And I'm going to tell you that the newer data would really have PALB2 up in the high-risk group, over 5-fold for breast cancer. And then out here on the right, you have these much lower risk changes, genetic variants, these SNPs. These are found from these large GWAS studies. And you can see that they're very common. Some of these genetic variants, 30% of the population can have them. But they don't confer a very high risk of cancer. For breast cancer here, the relative risk may be 1.2 or 1.4. It's always less than 2-fold increase. We used to have about 70 of these SNPs that increase the risk of breast cancer. A Nature paper just came out, big GWAS study, and there are 70 more. It really doubled it. So now there are 140 of these low-risk genetic variants for breast cancer. And what happens is you can multiply these different risks from these different variants. There's sort of an equation, there's a fudge factor. And what you get is this thing called a polygenic risk score. Now, my talk today is really going to focus more on these high and moderate risk genetic mutations. When you send a panel through the high-risk clinic or through Myriad or Ambry, this is what you're testing. Although, in the last week or two, Myriad has started to report this polygenic risk score, and nobody's exactly sure what to do with it. But today, we're really going to focus on the high and the moderate risk genes. So here is a list of potential breast cancer susceptibility genes, and this comes from a really nice review that Doug Easton led, and it's in the New England Journal from 2015. And Not on this list are the high-risk genes like BRCA1 and 2 and Li-Fraumeni, P53. Those are the syndromes we've known for a long time. These are the newer genes, and I'm going to show you more later, but these genes function in the DNA repair pathway that repairs double-strand DNA breaks, called homologous recombination. So here is PALB2, and as I told you before, this really has moved into the high-risk group since the risk of breast cancer is really over 5-fold. And then you've got genes like ATM and CHEK2, and you can see that they increase the risk of breast cancer about 2 to 3-fold. So then we have other genes on the list. NBN, again, works in that same pathway. A lot of controversy. Should it be on the list? Should it be off? I think you'll see it on and off different lists. Neurofibromatosis. This is really for patients who have clinical neurofibromatosis, the NF1 gene. And now we have these other genes, so let's just consider them for a moment. BRIP1, RAD51C, and RAD51D are 3 new ovarian cancer susceptibility genes. So when we send a panel and we find mutations in these 3 genes, we are talking to women about prophylactic oophorectomy. The risk of ovarian cancer isn't as high as BRCA1 and 2. Maybe lifetime risk is 6 to 10%, but high enough that we're considering it. But are they breast cancer susceptibility genes? They're found when you test families, because that's who you test, that have breast and ovarian cancer. But are they breast cancer susceptibility genes? So let's talk about BRIP1. A very large case control study, again in the UK by Doug Easton's group. When they looked at just breast cancer patients compared to controls, no increased risk of the mutations or no increased prevalence. So I think we're going to take BRIP1 off of the breast cancer and just leave it on the ovarian cancer list. What about the RAD51C and D? Again, lots of papers there and references on the right. You can find them in families with breast ovarian cancer. But if you look in families that just have breast cancer, you don't find an increase in these genes and these mutations. So I think for the moment we're going to take them off the list as well. How about BARD1? Again, just one of these genes that works in the same pathway as BRCA1 and 2 to repair double-strand DNA breaks. So Fergus Couch at Mayo Clinic, he did a large study of those with triple-negative breast cancer, over 1,800 women. He found 9 of them had BARD1 mutations. Is this enough to call it a breast cancer susceptibility gene? Is it just a coincidence? Not enough data yet to really have it on our list. So when I'm thinking for definite breast cancer susceptibility genes, it really boils down for the most part to ATM, CHEK2, and PALB2, in addition to the known high-risk syndrome genes. So with that, we're going to move forward. And first, say, how often do you find these mutations? If you have a breast cancer patient who looks like they have a strong family history, you test them for BRCA1 and 2, it's negative. You send a panel, one of these panels. How often are you going to find one of these other breast cancer susceptibility genes? I think the answer is about 4% of the time. We looked in patients from our high-risk clinic. We looked in patients, breast cancer patients who just came to the Dana-Farber, just walked through the door, and pretty much it's about 4% of the time. So let's start with BRCA1 and 2 and what's new and how should we think about that. So mutations only account for about 3 to 5% of breast cancer. A higher percentage of the patients with triple-negative breast cancer, so about 10 to 20%, will have a BRCA1 or 2 mutation, particularly because of the association with BRCA1. Up to 15% of Jewish patients who have breast cancer will have a BRCA1 or 2 mutation. Now, what kind of breast cancer do BRCA mutation carriers develop? Well, we know that for BRCA1, it tends to be estrogen receptor negative and really triple negative about 70% of the time. BRCA2 carriers, about 70 to 80% of the time, their breast cancer is ER positive. And for both, it's much less often HER2 positive. So for BRCA1, usually triple negative. For BRCA2, it's ER positive, HER2 negative, most commonly. Now, what about the ER positive breast cancers that the BRCA carriers develop? it tends to be what we call luminal B, this intrinsic subtype of the estrogen receptor positive breast cancers that tend to be higher grade. There are a few papers that show higher oncotype recurrence score. So really, the ER positive breast cancers that we tend to give chemotherapy to. So that's kind of an interesting difference. If you ask what is the prognosis for the breast cancer that a BRCA carrier forms, if you correct for all of the known prognostic factors, stage, grade, everything else, most of the studies will say that the prognosis is really the same. And this is one representative study, one of the largest from Pam Goodwin. Really no difference in prognosis if you correct for the prognostic factors. So let's start with management in our BRCA carriers with breast cancer. What about local treatment? So with the exception of data from Bruce Hafty when he was at Yale, he's really the only outlier, all the other data would say that the local recurrence is the same for a BRCA carrier and a non-carrier if they have breast-conserving therapy and radiation therapy. So no increase in local recurrence. So you can offer that to a BRCA carrier who has breast cancer. Now, what about partial breast irradiation? We don't really know because the BRCA carriers were excluded from all of those trials. But so you can offer breast-conserving therapy. But of course, the most difficult decision that our carriers with breast cancer struggle with is whether to have bilateral mastectomies because they want to prevent a subsequent breast cancer. And that's what we're really struggling in that moment when they're diagnosed, how to counsel them. So I wanted to make two or three points about that. So the first and most important is that the number one factor that predicts whether a BRCA carrier with breast cancer is going to get a second breast cancer, in the contralateral breast, over any period of time is the age at which they're diagnosed. The younger they are, the higher the risk. And it's not because they have more years to live. If you look over the next 10 years or 15 years or 20 years, the woman diagnosed at 35 is going to have a higher risk than the BRCA carrier diagnosed at 60. Why is that? It's because there are other factors, modifiers, both genetic and environmental, that are also affecting that risk. And the age of diagnosis reflects those modifiers. If it takes a woman till 65 to develop her breast cancer, maybe something more protective than the woman who developed it at 35. And that's true for BRCA carriers in all women, but it's true for BRCA carriers. So if you look, this is a recent paper in JAMA, but it confirms same thing, an older paper by a German group, Grazer et al., long time ago. I used to use that, now I use this. If you look at a BRCA carrier, BRCA2, who developed breast cancer before the age of 40, her risk of developing a contralateral breast cancer over the next 25 years is almost 70%. The same BRCA2 carrier, if she's diagnosed over the age of 50, her risk over the next 25 years is 20%. Such different risk estimates, you can imagine, would lead to very, very different choices in our BRCA carriers when they're diagnosed. So that's really my starting point when I talk to BRCA carriers about their risk of a subsequent breast cancer. Now, what about the data that says, is there an improvement in survival if a BRCA carrier has bilateral mastectomies? So let's examine that. There are 3 studies that have looked at that question. And these are specifically BRCA carriers with breast cancer, asking if they do bilateral mastectomies, do they have better survival? Now, of course, these are not randomized trials. You can't conduct a randomized trial. So if we look at these 3 studies, we see about 100 to 250 carriers in any of the studies opted for contralateral prophylactic mastectomy, and a larger number opted not to have mastectomies. Good long follow-up, up to 15 years in these studies. And each of these studies showed an improvement in either overall survival or breast cancer-specific survival for the carriers who did the bilateral mastectomies. So you think, well, that answers it, right? Not really. And it's because of this column. even though in each one of these studies, the time from the breast cancer diagnosis to the prophylactic mastectomies was short, 1 to 2 years, that's good. The problem is they allowed carriers out to like 20 years in some of these studies to choose prophylactic mastectomy. And that introduces a lot of selection because the carriers who were doing well and surviving may have opted for prophylactic mastectomies. If they recur in the first 2 or 3 years, they never get that opportunity. So there's a real bias here. And I wanted to tell you this so you have a response if somebody talks about these studies. In my mind, and I think the bottom line is if there's a survival advantage, it's incredibly small. That is not the reason to do the bilateral mastectomies. Now, in fairness, survival is not the only valid endpoint. You have to think about the stress of a new breast cancer diagnosis for your patients. Can they tolerate more chemotherapy? If a young woman's had triple negative and she gets her ACT and she's had left-sided radiation, if she gets another triple negative, how are you going to treat that? You have to consider the prognosis of the first breast cancer. When I see carriers who have 7, 8 positive lymph nodes and they want to do bilateral and deep flaps and all of that, I tend to want to caution them. Maybe we can wait 5 years and make sure everything is good before we start thinking about prevention and major reconstruction. But sometimes, that doesn't work. Consider the tolerance of your patient to endure the every 6-month surveillance with MRI and mammograms and the false positives and the biopsies and all of that. So I think this is really the kind of discussion I have. But I start from the place of giving them an accurate number of what's their chance of getting a second breast cancer in the next 20, 25 years. So now I want to turn, still on the BRCA carriers, and talk about the systemic therapy. And I really want to focus on 2 things, platinum and PARP inhibitors. So we'll start with platinum. So over here on the right, I've shown you that BRCA1 and 2 down here work in the homologous recombination pathway. And what is that? That is the pathway that repairs double-strand DNA breaks. Now, what does platinum do? Platinum creates these intra and inter-DNA sort of adducts. And that's usually repaired by a different pathway, nucleotide excision repair pathway, but it's also repaired by BRCA1 and 2 in this homologous recombination pathway. And that's probably because platinum ultimately causes double-strand DNA breaks. So BRCA1 and 2 are important for this as well. So I'm going to talk to you about platinum and BRCA carriers. I'm going to focus on 3 studies. Okay, so this is the first one, and it's in the metastatic setting. So the TNT trial was a trial for patients with metastatic triple-negative breast cancer in their first-line setting. But the study also allowed any BRCA carrier. So there were 43, most of them were triple negative, they had 12 ER positive. So in the study, patients were randomized to either get carboplatin or Taxotere, docetaxel, and then when they progressed, they crossed over. And there was always a pre-planned analysis to look at the results by BRCA status. So what did they find? For all of the patients, the whole study, it was basically negative. There was no difference between platinum and docetaxel, except in the BRCA carriers. And for those 43, there was a higher, significantly higher response rate with the carboplatin and a longer progression-free survival. So take-home message, in the metastatic setting, platinum was better than docetaxel for BRCA carriers. That was number 1. What about for newly diagnosed BRCA carriers with breast cancer? So the largest data that we have is from Poland, and they've been giving neoadjuvant cisplatin, 4 doses, to their BRCA carriers with breast cancer when they're diagnosed. They're pretty much all BRCA1 carriers, and usually with triple negative. But their last report in 2014 had 107. There were 16 ER positive, but again, they're mostly triple negative. And they reported this incredibly high path-CR rate of 61%. Now, there's one problem with that. And the problem is that this cohort was incredibly favorable. They were small cancers. Half of them were less than 2 centimeters, and more importantly, 2/3 of the women were node negative. These are not the typical women we're giving neoadjuvant chemo to. So platinum's certainly active, but is this any better than if we took the same patients and gave them standard chemotherapy? We don't know, but we're asking that question. Whoops. And we've been doing the INFORM trial for a number of years. And the target is 170 BRCA carriers, HER2-negative breast cancer, newly diagnosed. And what we're doing is after they get a research biopsy, they're randomized to that same regimen, the cisplatin, which we've been using at the Dana-Farber for many years in triple negative, versus Cytoxan Adriamycin. And the primary endpoint is path-CR. After they have their surgery, physicians can use any other chemo that they want to at that point. And so we're over halfway accrued, chugging along. So this will be the only one that really compares platinum to standard chemo in BRCA carriers. One more study I want to show you in BRCA carriers with platinum. And that's really answering the question, does platinum add to standard chemotherapy for breast cancer in BRCA carriers? And before I show you the study, just to refresh your memory, for triple-negative breast cancer, we have 2 studies now, a CA-LGB study and a German study, gBRCA. These 2 studies have shown that for triple-negative breast cancer patients in the neoadjuvant setting, if you add platinum to the standard ACT or anthracycline and taxane-based regimen, you improve path-CR rate. That's been shown. One of the 2 studies, the German one, looked specifically by the BRCA status. So that's what we'll focus on for the moment. So here's the regimen. It's a funny one. They give simultaneously weekly Taxol and basically weekly Doxil and some bevacizumab, and then they randomize patients to weekly carbo or not. That was their study. And what did they find? It's interesting. In the non-BRCA carriers, carboplatin here on the right significantly improved the path-CR rate. So that's what we just said, and that's consistent. But if we look in the BRCA carriers, there was no benefit from adding the carboplatin. This was just published in JAMA Oncology. No benefit. And it's probably because if you look here, the path-CR rate in the BRCA carriers without the platinum was better than the non-BRCA carriers with the addition of carboplatin. And again, the numbers are small, but it sort of suggests that maybe the reason you don't get more bang for your buck when you add the platinum to the BRCA carriers is because their breast cancers are already so sensitive to chemotherapy that you're just not getting any more benefit. So, and the 3-year disease-free survival, same thing. Benefit for the non-carriers, not for the BRCA carriers. This was kind of surprising. Again, I think we have to remember the numbers are small. And so if I show you here are my conclusions when I think about platinum for BRCA carriers. It's active, no doubt, better than Taxotere in the first-line setting. It may not add anything to standard chemo because the breast cancers are already so chemosensitive. Almost all the data is for triple negative. So what's unanswered? Is it better than standard chemo? And is it active in the ER-positive breast cancers in the BRCA carriers? And we're hoping to answer those 2 questions in our trial, the INFORM trial that I showed you. And I think of those 3 papers, you can remember that the number of BRCA carriers in any one of these studies, again, is pretty small. So now I wanted to move on to PARP inhibitors, which hopefully will be somewhat relevant, to some other cancers as well. So the 3 PARP inhibitors, olaparib, rucaparib, and niraparib, are 3 PARP inhibitors that have now been FDA approved for use in ovarian cancer, different settings. Veliparib and talazoparib are still in clinical trials, are not yet FDA approved. So how do PARP inhibitors work? Well, we've been taught the last several years that they work because they inhibit the repair of a single-strand DNA break. And when a cell with an unrepaired single-strand break goes to replicate, that becomes a double-strand break. And so if a cancer cell doesn't have BRCA or doesn't have homologous recombination and it can't repair a double-strand break, then it'll be lethal. So that's what they call synthetic lethality. You need both. So the cancer cell cannot repair the double-strand break. Now you introduce an inability to repair the single-strand break. You need both, and then the cell will die. That's what we've been taught. Now, the last couple of years, we've heard about another mechanism called PARP trapping, which simply means that the PARP inhibitor sort of traps the PARP proteins or the PARP enzymes on the DNA and don't allow them to work. And if that's the case, it may actually be lethal to cancer cells that do have functioning homologous recombination or BRCA. So it's just another mechanism that's being touted. The different PARP inhibitors have different potency for this PARP trapping, which for the moment is thought to be the most important mechanism. So you see talazoparib here at the top, the most potent. Veliparib is the least potent, and olaparib, which I'm going to show you data, is sort of in the middle. Does this potency translate to differences in efficacy? We don't know yet. Will it translate to differences in toxicity? Don't know yet. Although cross-study comparisons are tough, I do sort of think we're seeing more thrombocytopenia and neutropenia with talazoparib in the results that are coming out. But we don't know yet. So let me talk to you about PARP inhibitors in breast cancer. Olaparib was the first one on the scene. So that's where we have most of the data. And the first study was the iceberg trial. And these were pretty heavily pretreated breast cancer patients, metastatic, BRCA mutations. They had to have had at least one chemo in the metastatic setting. Most of them had more. Median was 3. And very impressive. 41% response rate with a pill where you don't lose your hair, and I'll show you the side effects, not very much. Responses in both ER positive, ER negative. This was very, very exciting. And it was proof of principle that if you block the ability to repair a single strand break, you're going to get a response in a tumor cell that has no BRCA. So it was really very elegant and very exciting. Next was something called Study 42. So this was a basket study. This had BRCA carriers with many different kinds of cancers, pancreatic, prostate, all different kinds of cancers. There were 62 that had breast cancer. We're just focusing on breast cancer now. And more heavily pretreated. You had to have had at least 3 chemos in the metastatic setting. So it's not surprising that the response rate was going to be lower, only 13%. But there was an interesting finding in this study across really all the cancers, and that was that if the patient had seen prior platinum, the response rate was lower. And you see here for breast cancer, it was only 9% compared to the breast cancer patients who'd never seen platinum, and it was 20%. What was going on? Well, for the first time, people started to think, well, maybe the mechanisms of action are redundant. If platinum and PARP inhibitors both depend on a cancer cell being deficient in this homologous recombination, then maybe they're going to be cross-resistant or there's going to be tolerance. So we'll keep this in mind and explore this. So next came the OlympiAD trial. This was presented at the plenary session at ASCO last June and published the same day in the New England Journal, and Mark presented it. So this was a study that was comparing PARP inhibitor to chemo. So it was a randomized phase 3 trial, BRCA carriers, breast cancer in the metastatic setting, HER2 negative. And they were randomized to olaparib or to the physician's choice of chemotherapy. Notice that platinum is not one of these choices. Okay. And the primary endpoint is progression-free survival. There were a number of secondary endpoints, survival and toxicity, and I'm going to show you some of those. What were the results? So it was a positive study. There was a significantly improved progression-free survival with olaparib compared to chemotherapy. There was no improvement in overall survival with about 77% of the data mature. I think it's going to be really hard to show a survival advantage because for the patients on chemo, when they progressed, half of them, the very next regimen was a PARP inhibitor or platinum. I think it's just going to be very hard to show a survival advantage. For those patients, breast cancer patients who had measurable disease, the response rate was more than double with the PARP inhibitor. And I find this important. The median time to response was the same. So for my triple-negative breast cancer patient who's progressing rapidly, if they're going to respond, the time to response for olaparib is the same as chemo. So that's important to me to know. So what were the side effects? Well, the serious ones, grade 3 or higher, were lower with the olaparib than with chemotherapy. For those who haven't used the PARP inhibitor olaparib, it's really pretty mild. Patients may have mild nausea, maybe a little fatigue, sometimes a headache. About 17% can have a nagging, a little annoying cough. But it's really grade 1, grade 2. They don't lose their hair. It's pretty well tolerated. The number one grade 3 or higher side effect is actually anemia. They can develop a high MCV anemia. Not much neutropenia or thrombocytopenia. Only 5% of the patients stopped the drug because of side effects. And every health-related quality of life measure that was measured in the study favored olaparib to chemo. So this was really, I think, for us in the study, very exciting. This is a forest plot that asks, are there any subgroups for which olaparib was not better? And I caution that this is exploratory because it wasn't a pre-planned analysis. So I want to focus on the estrogen receptor status. You see here that the hazard ratio, so over here it favors olaparib, over here it favors chemo. It looks like the hazard ratio is less impressive for the breast cancer patients with ER-positive disease. And I've seen people misrepresent this and say it's less effective in ER-positive disease. I don't think that's true, because if you look here, this is the response rate for those who had measurable disease. With olaparib, the response rate was actually higher in the patients that had ER-positive disease and triple-negative disease. But you have to remember that the hazard ratio was a comparison between how good olaparib was and how good chemo was. And in this study, the chemotherapy was also better in the patients with ER-positive disease, so the comparison looked less impressive. But it definitely, ER-positive breast cancers do respond. The next interesting subgroup to ask the question is that platinum. Now the problem is we can't make any comment about patients who progressed on platinum because they weren't allowed in the study. So you had to have been 12 months away from your last platinum. You couldn't have progressed on platinum. So at least if you'd been exposed to prior platinum, there didn't seem to be any difference with response to olaparib. But again, we can't say anything about progression. So what do we know about that? If you get platinum and you progress, are you going to respond to a PARP inhibitor? So let's look at ovarian cancer first, where there's way more data. For any of you who treat ovarian cancer patients, they have these definitions. Platinum sensitive, meaning the ovarian cancer progresses more than 6 months from the last platinum exposure. Platinum resistant, it's progressed within 6 months of the last platinum. And platinum refractory, it's progressed while getting platinum. And you can see that the response to olaparib, or the PARP inhibitor, goes down, and it's really 0% by RECIST if you're progressing on platinum. So that's an ovarian, and sort of seems consistent with our theory about these redundant mechanisms of action. What about in breast cancer? Well, I was very interested when this was presented at ASCO last June. This is a different PARP inhibitor. It was at the top of the list for potency that I showed you, talazoparib. And they presented the results of their phase 2 study. And in this cohort, there was no prior platinum, and in this one, there was prior platinum. So interesting, higher response rate, no prior platinum. But what I was really interested in this study, nobody was supposed to be eligible if they'd had platinum in the last 8 weeks. But somehow, I don't know, 7 patients seemed to slip through, and none of them had a response rate to this PARP inhibitor, even the more potent one. So I think that if you've progressed on platinum, it seems pretty unlikely you're going to respond to a PARP inhibitor. What about the opposite? What if you get your olaparib first or your PARP inhibitor and you progress? Can you then use platinum? Is it going to work? So not much data, but in ovarian cancer, in this one study, the answer was yes. They got a 40 to 49% response rate, depending on how you define the response, CA-125 or RECIST, using a PARP inhibitor after platinum progression. So that was pretty good. In breast, the only data I know of is Jeff Weitzel had one study where patients were on voliparib, and if they progressed with their breast cancer, platinum was added. And only one of the 30 got a response when platinum was added. So again, I think a lot of redundancy for breast. So we know platinum's good from the TNT trial, was better than Taxotere. We know PARP inhibitor's good. I just showed you the OlympiAD trial. Which is better? Which should you reach for in a metastatic breast cancer BRCA carrier? So there's no direct comparison, so it's just us. We're going to do what we're not supposed to, cross-study comparison, and look at these two trials. So TNT was the first-line setting. Olaparib was up to third-line setting. TNT was pretty much all triple negative, few ER positive. The PARP inhibitor study, OlympiAD, had both. And if you look at the progression-free survival, it's really about the same. If you look at the response rate, especially just for first line, it really looks about the same. But I would say that I think the toxicity with olaparib or PARP inhibitor would be much lower. So where are we? This is a summary table for PARP inhibitors in breast cancer, in BRCA particularly. So let's go through it. Here are different PARP inhibitors. Olaparib, we just talked about the OlympiAD trial in the metastatic setting. And AD, don't get confused, is for advanced breast cancer, metastatic, whereas over here, the A is for adjuvant. So olaparib is now being studied in BRCA carriers with early breast cancer, adjuvant, placebo versus olaparib when they're all done with their chemo and local therapy and endocrine. So that study's going on. Interestingly, both niraparib and talazoparib in the metastatic setting are conducting studies identical to the OlympiAD trial I just showed you. We've been told that the Bravo trial may not give us any meaningful results because the patients that were randomized to the chemo, not the PARP, but the chemo, are dropping out before the first radiologic assessment, which is really a pity. But we'll see if the BRCA trial confirms the positive results with a different PARP inhibitor, as we just talked about. I think that Jen Litton has an interesting study. She's just completed enrollment at MD Anderson. She's using the talazoparib, that potent PARP inhibitor, in the neoadjuvant setting as monotherapy, just the PARP inhibitor, for 4 to 6 months, and she's measuring path CR rate. I think that's be a very interesting finding. Rucaparib, not really studying BRCA carriers in the metastatic setting. They're looking at more tumors with LOH and homologous recombination deficiency. We'll talk more about that. In the early setting, I think rucaparib has a very interesting study. This is the Hoosier Oncology Group. And what they're doing is taking patients with triple negative disease or BRCA, could be either. You get your neoadjuvant chemo, you have residual disease after surgery, and they're randomizing the patients to cisplatin with or without the PARP inhibitor rucaparib. I think that's going to be a really interesting study. And then voliparib, the study that they're doing is called BROCADE-3. Again, we're in the metastatic setting. BRCA carriers randomized to Taxol and carbo, or Taxol, carbo, and voliparib. Interestingly, the phase 2 randomized trial, the BROCADE-2, was just published in the Annals of Oncology, and it was a negative study. But I think they felt it was underpowered, so they went on to do the phase 3. So we'll wait and see those results. I think that the BROCADE-3 and the Hoosier Oncology Group study raise an interesting question. It's a good segue. If PARP inhibitors are good and platinum is good, why don't we combine chemo and PARP inhibitors, and particularly platinum? Why don't we just do that? The problem is it's very hard to combine PARP inhibitors with chemotherapy because there's so much myelosuppression. We did a phase 1 study Judith Balmania in Spain, Judy Garber and I at the Farber. We did a phase 1 trial together using cisplatin and olaparib in all comers. Most of the patients, as you see in the light green in the waterfall plot, had BRCA mutations. And you can see it was a phenomenal response. It's just that we had to keep decreasing the olaparib dose. We can only give it 5 days out of 21. The platinum we had to decrease. We felt like we just kept decreasing. There was so much myelosuppression. But again, in the BRCA carriers with breast cancer, I mean, very, very high response rates. So I know that this will be an approach carried forward, but it is a challenging one. So you give a PARP inhibitor, it's working, but then it stops working. What are the mechanisms of resistance? That would be a whole nother hour-long talk that I don't have time for, but I do want to talk about one established mechanism of resistance, and that is these reversion mutations that you hear about. So what are those? Reversion mutation is a second mutation in the BRCA gene that restores the reading frame, so it restores the BRCA function and homologous recombination. And I'll show you a case of that. So this was, and it can happen being exposed to PARP inhibitors, it can happen being exposed to platinum or chemotherapy. So this was a patient who was in a neoadjuvant study, PrECOG 0105, BRCA carrier. She was getting 6 doses of platinum-based neoadjuvant chemo. She was born, she inherited a 2 base pair deletion in the BRCA1 gene. After the 6 doses of platinum chemo, when her tumor was resected, the tumor had developed or acquired 40 more base pair deletions, so the total was 42. And of course, because every 3 base pairs translate to 1 amino acid, anytime your deletion or insertion, anytime the change is a multiple of 3, you can actually get right back into your reading frame for the BRCA1 or the BRCA2. And that's what happened with this patient who recurred very quickly after, was resistant to absolutely everything that was given, and passed away. So that's sort of a challenging thing. What's interesting is that sometimes you can find these reversion mutations in the blood, in the circulating free DNA. So here's a paper that shows that, really exciting. So this were BRCA carriers, ovarian cancer. The ovarian cancer recurs. They found that 5 of the ovarian cancers had a reversion mutation, and in 3 of the patients they could find it in the blood, in the circulating free DNA. So this is the way forward, because how much better, particularly in breast I think about it, how much better if we didn't have to keep biopsying the tumor, we could find it in the blood, and if I found a reversion mutation, it would really make me think twice about using platinum or PARP inhibitor in that BRCA carrier. So I wanted to talk about immune therapy before we go on to all the other new, more moderate genes. There's a lot of excitement, a lot of talk about immune therapy in BRCA cancers in general. Why is that? So there's a lot of excitement about using immune therapy for those tumors that have microsatellite instability, the Lynch-related tumors. And we think that it works because there's a high mutational load in the tumors, lots of neoantigens. And if I show you this, so here is the mutational load in cancers associated with different mutations. And you see here the mismatch repair mutations, the Lynch tumors, high mutational load. Tumors that have POL-E mutations, high. UV-related cancers, high. But look at BRCA, not very high. So what's all the excitement about using immune therapy? Well, the mutational load for BRCA cancers may not be high compared to Lynch, but some of the literature says that if you look among triple-negative breast cancers, those BRCA carriers, their tumors have a higher mutational load. When you look at the tumors under the microscope, they certainly have a lot of tumor-infiltrating lymphocytes. It's particularly the BRCA1 triple negatives, so they seem to be immunologically kind of hot tumors. There's some data that HR deficiency is immunogenic. Using PARP inhibitors creates neoantigens through all these somatic mutations. This is all kind of theoretic, but this is the basis for many, many, many studies you're going to see combining PARP inhibitors and immune therapy and chemotherapy. And there are 2 specifically I listed there for BRCA carriers, but this is the rationale, the best I can get from all of the literature. So let's turn our attention to those other more moderate risk genes. Here's our list. Again, PALB2, ATM, CHEK2, really dominating our list for breast. And I want to point out this truncating and missense for those who don't do a lot of genetics, and make the point that different mutations may confer different risks in these genes. We don't say that for BRCA1 and BRCA2 because they're so high risk, but for these more moderate risk ones, different mutations do. So, CHEK2, the most common mutation that you read about when you read about CHEK2 in the literature is this 1100 del C, deletion of one base pair, the C. And this one mutation confers a 2 to 3-fold increased risk of breast cancer. But there are 2 very, very more common missense mutations, meaning just one base pair is changed for another one. There's no deletion or insertion, just one base pair is changed. And it's the I157T and this one, the S428F. These are more common in the Jewish population, and the relative risk is much lower, 1.5. In fact, some of the companies don't list them as mutations. They sort of put them down with the variants, more like those SNPs we were talking about, and others report it as a mutation. So you have to sort of know that there are different risks with different mutations. Interestingly, for ATM, the story sort of emerging feels reversed to me. There are some missense changes, single base pair changes, that really have very high risks of breast cancer, over 10-fold, whereas some of the frame shift or truncating mutations have that 2 to 3-fold. So it's tricky, and it's really, the story is just emerging at this point. But just be careful about that. Not all mutations are created equal when you're talking about genes with a lower risk, not those really high ones like BRCA1 or 2. So let's talk a little bit about our breast cancer patients who have these newer mutations. We get the panel back. What is it supposed to mean for our management? Talk about local care. There's a lot about, is it safe to give radiation to those with an ATM mutation? What about risk of a second or contralateral breast cancer? Do they need mastectomies? So let's start, and here's the picture. Maybe I should have shown this earlier. Here's our homologous recombination pathway. Here's our double-strand break. Here it is repaired. The pathway is also called Fanconi anemia, BRCA. I won't go into why. Here's the proteins, BRCA1 and 2. They work in this pathway. Here are our other genes, ATM, CHEK2, PALB2. They're working right there in the mix for the same DNA repair pathway. So for many years, it's been questioned. 20 years ago, for BRCA, people said, isn't radiation going to be dangerous? You're going to create all those double-strand breaks, and you're not going to be able to repair them. There's going to be so much toxicity. There's not. The literature and the clinical shows there's not. You're going to give radiation, and there's going to be more radiation-induced breast cancers in the other breast. Never happened. Literature says it doesn't happen. So a lot about ATM, though. There seems to be a feeling that the risk may be higher with ATM. The data and the literature is so old, but the only recent data we have for ATM comes from a group, a cohort, the We Care study. What is the We Care study? It's a cohort of women who are diagnosed with breast cancer before the age of 50. That's how they enroll. And then they're followed, and they're looking for risk factors that predict for bilateral or contralateral subsequent breast cancer. So they looked at ATM, and what they found was for the more common ATM mutations, more than 1% of the study population, no increased risk of a bilateral breast cancer if you got radiation on the first one. So that seems fine. They did raise the question that for some of the rarer ATM mutations, less than 1% of the study population, there might be an increased risk. I think it's all still emerging. I tell my ATM patients who have breast cancer that they can have breast-conserving therapy if they want to. I don't think about the radiation as a contraindication. What about contralateral breast cancer? What about the need for bilateral mastectomies? And let's just remember, we had a hard time proving it was necessary for BRCA. It's going to be a lot harder to show for these more moderate risk genes. There isn't much data. This is for PALB2, the one study that I thought was decent. So the 5-year risk, a woman develops breast cancer, what's her 5-year risk of getting a contralateral breast cancer? 10% for PALB2, so about 2% per year. Lower than BRCA1, obviously higher than if there's neither mutation. So about 2% per year there in this study for PALB2. What about CHEK2? Well, first I should tell you that CHEK2 predisposes to estrogen receptor positive breast cancers almost always. So for the woman who did develop an ER-positive breast cancer, she inherited a CHEK2 mutation. Her 10-year risk of a contralateral breast cancer is 12 to 15%, so lower than that PALB2. It's not 2% per year, but it is increased. You know, is this enough to be telling people they should have bilateral mastectomies? No, I don't think so. Is it enough to suggest an MRI for surveillance? Absolutely. ATM, CHEK2, PALB2, I would say absolutely yes. So I think this whole issue, I mean, especially CHEK2, I can tell you with a large practice, there's a lot of bilateral breast cancer, for sure. But how do we, with such little data, how do we really advise our patients? So I don't think it's going to impact their survival. I do think we should borrow from what we just talked about for BRCA1 and 2. I think a very young patient who has a strong family history, those things influence me to talk about bilateral mastectomies. And what about systemic therapy for this ATM, CHEK2, PALB2? Well, the chemo's the same. No data for platinum. We don't yet really have data for PARP inhibitors. But let's talk about that, because I think it's an interesting concept for prostate and other cancers that's happening. If we step back for a second and ask, are there any other populations of breast cancer or other cancer patients that we can think of that might respond to a PARP inhibitor other than the BRCA1 or 2 carriers? I would offer 3 potential populations. The first are patients whose tumor has an acquired BRCA mutation. They didn't inherit it, it's acquired. And we know from prostate cancer, they seem to respond to PARP inhibitors. The second are these assays that try to measure homologous recombination deficiency. So forget about looking for the mutations, just look at the function of that pathway. Myriad had a tool. They tried to study it. It didn't seem like it was going anywhere. There's a new one called HR Detect that has whole genome sequencing. Nature published a paper a year ago. Looks exciting. Will it make its way into the clinic? I don't know. And finally, as my last slide, or a couple slides, what about mutations in these other genes? ATM, CHEK2, PALB2, these other ones. And this was the TOPARP study in prostate cancer, castrate-resistant prostate cancer. What they found was that patients with metastatic prostate who did have mutations in these other genes like ATM, they did respond to olaparib. So we are doing that in breast cancer now. It's called olaparib expanded. And we are studying patients with metastatic breast cancer who either have inherited or somatically acquired mutations in all these DNA repair genes to see if they'll respond to olaparib. And I think I'll stop there so that we can do questions. I can go on to the unaffected, but should I stop and do questions or a couple more slides? Questions, okay. So, any questions? Yes. Yeah, that was on my list, the immune, yeah.
The additional interest in head neck cancer is that, you know, we have interest in these DNA repair mechanisms, but also it's an immune, it's a cancer where the immune system may play a role, so it may make the combination effect. Do you agree that platinum?
Yeah, absolutely. So the question is, could we use platinum to sort of think about which tumors might be more sensitive to PARP inhibitor? And that's actually, we've talked about that for a long time, we investigators. Why don't you use that as sort of a predictor? So to give platinum in any cancer, and if they respond, don't give it long enough that they're going to get those reversion mutations or whatever, but just sort of use it to sort of select patients who might have DNA repair deficiencies respond to platinum, give 2 or 3 cycles, and then switch to a PARP inhibitor. So I think it's a wonderful approach, and we've definitely suggested it several times to different, I think it's a very clever question and a good approach. Here's the mediola, by the way. It's olaparib and durvalumab, that immune therapy for all solid tumors. But these are BRCA carriers. What you're asking is a really more elegant question about using the platinum as sort of a functional test to see if the tumor might have HR deficiency and then be sensitive to PARP inhibitor. Yes?
If I can follow, I'll just ask, is there any indication that these regular tumors may be more sensitive to radiation?
So that was always the fear, that they would have more toxicity, but they don't. They seem to have the same amount of toxicity after radiation. They don't necessarily have a better response, in the metastatic setting, at least clinically that I've seen. And again, the fear of the radiation-induced contralateral breast cancer, that never happened. So it's theoretic that they should, but it hasn't really translated to clinical. Question was whether BRCA cancers are more sensitive to radiation because of their deficiency.
And what about the combination with platinum? I mean, I'm not a breast doc, but my memory is that platinum's a good radiation.
It absolutely is. Cervical cancer for anybody, So it is a radiation sensitizer. I don't know that there's any difference in the BRCA carriers versus the non-carriers. Yes?
Yeah, thank you for the talk. Couple of questions. So your data about the triple-negative breast cancer that was sensitive to carboplatin, but the addition of PARP inhibitor to that regimen did not further improve response rate.
Well, they didn't.
Going by the hazard ratio.
They didn't add PARP inhibitor to that. So the studies I showed you for the metastatic triple negative was that platinum was better than Taxotere. Platinum didn't seem to add if you had already given the standard chemo, maybe because the standard chemo did the job by itself. We know the study I showed with PARP inhibitor, OlympiAD, was PARP inhibitor compared with chemo, and the PARP inhibitor was better. So what I was trying to show you in my table, my no-no table, was we have one showing PARP inhibitors better than standard chemo. We have platinum better than Taxotere. Which is better, platinum or PARP inhibitor? And we don't really know.
So my question is, what do you think the better strategy would be? Is it to use PARP inhibitors as sensitizing agent for platinum, since we know that platinum is already effective in a lot of patients? Or should PARP inhibitor be used to enhance activity of platinum that you know is already there?
Right. So this is the gazillion-dollar question, which you've hit the nail on the head, is how should we be using the PARP inhibitors? Should we use them by themselves? They seem to respond, but a lot of people do develop resistance. Should we do it by themselves? Should we combine it with platinum to sensitize to the platinum? This is really what people are trying to figure out. I will tell you, in our phase 1 trial, I showed you we did the study combining the platinum and the olaparib. We had to dose reduce so much. But we got great responses. And then after 4 to 6 cycles, people, the toxicity of the platinum, you could stop the platinum and just stay on the PARP inhibitor. And boy, oh boy, we had a number of patients that really had long responses to the PARP inhibitor. So secretly in my heart, I've always liked the approach of sort of doing the combination, or maybe doing the platinum to select, and then sort of leading with the PARP inhibitor for a long time. So I think these sequencing questions about how to use them are really, you're really at the forefront of what researchers are probably trying to figure out at this time.
And my last comment.
Yeah, that's okay.
Yeah, so we've done a lot of work with PARP in combination with chemo, and what we realized was the sequence and the time when you use the PARP inhibitor actually matters. The original phase 1, which was done in heavily pretreated patients using olaparib, we actually observed that you're not able to go above 20 milligram PID of olaparib. But the same population, including breast cancer patients, when you take that into the front line, frontline patients were able to dose them to 100 milligrams PID of olaparib in combination with platinum and paclitaxel. And we just completed a phase 2 in small cell, where we did the same combination with cisplatin and etoposide, no problem at all.
Yeah.
We were able to combine olaparib at full dose. So I think figuring out when you're going to get the maximum benefit from the PARP inhibitor would be very important. Not just whether it works, but actually when do you get the maximum benefit. And I think the earlier you use it in the course of the treatment,
the less toxicity and the more and actually that approach, I showed you the Brocade 3 trial on veliparib. They're doing Taxol carbo with or without veliparib. So clearly veliparib, whether it's a less potent PARP inhibitor and that's why they're getting away with it more, or just whatever, but I'll be really curious to see that in breast and other cancers as well. There was a question over there. No. So the question was for ATM check2, PALB2, these other mutations, they get chemo, do they have a higher chance of leukemia? Not that we are aware of at this point. I thought you were going to ask me PARP inhibitor leukemia, MDS, but nope, not. But again, we're really just starting. I mean, it's really just the prostate cancer paper using olaparib and those mutations. I think we are at the very beginning of this story, but not that I know of. All right. Thank you.